Okay, ma'am, we are live.
Yeah. Hi, everyone. Good evening. So, this is one of the interesting sessions in immunology. So, this is session number 8. We will be talking about thymosin. So, thymosin is like a new kid in the block where it got a lot of attention during the COVID, where it was used for immunomodulation in COVID patients who were going through cytokine storms. So, here the thymosin, whatever the effect it had on immunomodulation during that time, the same thing was copy pasted in immunology of pregnancy, and then there were papers and research papers which told that thymosin can be used in patients with recurrent implantation failure and recurrent miscarriages and stuff like that. So this is again a gray area where some people think that it is like really a wonder drug, and Dr. Jay has immense experience. Now there are so many companies which are marketing very aggressively about thymosin, and they are saying like, I mean, it is the next almost like a steroid. So whether it is really useful, not useful, and in if it is useful, which cases it will really be useful is what the class is about today. And the costing also we have to take into consideration. Also we need to like work out on the practical aspects of when to give, how to give, how much to give, how much to actually like push the patient, and exactly when to stop. So today's class is mainly on thymosin. Any questions we will be willing to answer on our groups. So over to you.
So I'll start with the screen sharing. Just let me know if the screen is visible, okay, ma'am? Is it visible?
Yeah.
Fine. So, friends, one thing which is important to understand about thymosin is that thymosin is a drug which is produced from the thymus gland. Okay. And thymus gland is predominantly active till approximately puberty. Okay. So, in till puberty, from childhood to puberty, it produces thymosin alpha, and then it also produces beta 4. That is the main function of the thymus gland. Simultaneously, thymus gland plays a very important role of recognition of autoantigens. That means what belongs to you and what belongs to outside. So that thymosin, the thymus gland plays a very important role, because in that stage of development, once somebody touches adulthood, by that time every immunity has been completely matured. And because immunity is completely matured post adolescence, I mean usually in that window of adolescence, this gland begins to undergo atrophy. So thymus gland would then, get reduced. So all the production post adolescence of all these drugs which the thymus is otherwise producing is going to go down drastically. So basically the native concentration of thymosin alpha is otherwise negligible. So that there comes the role of thymosin alpha, the exact thing which it does in childhood. It balances the immune system. So that is important. It just balances the immunity. We don't really know it does what where. I mean, we don't really know if it does TH1 to TH2 alteration, if it does TH2 to TH1 alteration, if it stabilizes the uterine natural killer cells, it basically stabilizes any peripheral killer cells. So basically stabilization of NK cell activity. It, stabilizes the immune system responses. Okay, so we don't really know the exact mechanism of action in which thymosin alpha will work, and as a result of which we do not know thymosin alpha's exact mechanism in recurrent pregnancy loss, recurrent implantation failures. But we know one thing: any place where immunity is slightly affected, for example, imbalance in immunity is common in two conditions in gynecology. One is endometriosis, as we are all aware, and adenomyosis, obviously. And second is all forms of autoimmune diseases. Correct? Once upon a time, we were using thymosin alpha in patients who are having a lot of peritoneal endometriosis. Shilpa madam is aware about this because in along with Bombay, we were also doing it in Hyderabad and also doing it in Bangalore. A lot of thymosin alpha was used by us initially, and I think we continued it. I think Shilpa madam must have used 200-300 vials. I would have used close to maybe 2000 vials here. Aarti madam would have used probably, I think, 150 to 200 vials of thymosin alpha. And what we have concluded as far as endometriosis is concerned is this. Okay. And I will write it down, thymosin alpha here. So as far as endometriosis is concerned, so I'll write down the disease wise. The answer is I don't know at the moment. Okay. I don't know if it reduces the peripheral pain. I do not know it reduces the recurrence or not. I do not know. Okay. And as a result of which, from 2025 onwards, we stopped using it. In fact, in Bangalore, we stopped using it at the end of 2024. Bombay, we stopped using it at December 2024. Hyderabad, we stopped using it, I think, January 2025, because I am myself not sure. Obviously, guys, as you are all aware, there is no publication to this. Even I don't have a publication. We have submitted it for publication. But the problem which came in our publication when we applied for it the first time is we did not have a control group. So we did not really know, we could not divide people into a control group of people whom we gave and people whom we did not give. And the second problem which we faced was we face a lot of recurrences of endometriosis at all centers. So we never had so many native cases. And that is why, as far as thymosin alpha in endometriosis is concerned, I've written I don't know. Correct? Now, when it comes to thymosin alpha in recurrent pregnancy loss and recurrent implantation failure. See, first thing you have to understand, we don't know what the dosages are. So I do understand that in India, there are 3 companies which are marketing this product very, very aggressively. Okay. Thinking that it is wonderful, this, that. But there is no standardization of dosage. People will tell you that you can give it every alternate day. Okay. But remember one thing, this alternate day dosage does not really work, in my opinion. If thymosin alpha is to be given to a patient, what I believe is that it has to be given in the previous cycle and it has to be started from the luteal phase. So that means probably day 20, 21 or 22 of the previous cycle before embryo transfer. You need to continue it till embryo transfer. Probable dosing should be thrice a week. Probable dose for this should be approximately 1.6 to 3.2 grams per week. And it probably should be continued for at least 9 to 10 weeks of gestation. But the question is, should we use it in RIF and RPL alone? I mean, should you only give thymosin and not give anything else? That means, should you not give Vizolone? Should you not give, let's say, tacrolimus? Should you not give intralipids? Should you not give IVIG? Okay. So my answer to this is very simple. Actually, I have never, or I don't think there is any publication for that. Even the smaller studies which are available, which are believed to be published studies, they do not really end up having any form of data on usage of this drug alone. Everywhere it has been used as an adjunct. That means at every place it has been used as an adjunct in failed cases. Okay. So what should be the criteria? So this is what I think should be the probable criteria for using thymosin alpha in an Indian scenario. Okay. One, you should have a normal pelvis. You can't have fulminating grade 4 endometriosis inside, and with grade 4 endometriosis inside, you are using thymosin alpha. That is stupidity. It cannot alter an immunity in an already altered immunity, right? You can't be doing that. So you first need to have a normal pelvis. Your preference second should be to have a euploid embryo. Okay. And third, you should only use it as an adjunct therapy. I do not think thymosin alpha should be promoted as a monotherapy. Obviously, guys, these are my thoughts. As you are aware, we as such do not really have any massive data which is available anywhere across the world for the usage of this particular drug is concerned. And that's why it should be used only as an adjunct therapy. Now, second question, which Shilpa madam addressed very nicely, and that was the cost of the therapy. Cost of Vizolone for the first 12 weeks to the patient comes to less than 1,000 rupees, right from previous luteal phase. Cost of single injection of thymosin alpha is going to be 1000 rupees, right? It is expensive. As a result of this, when you are using such an expensive injection, we prefer to take a consent that it is an experimental module. We do not think it is a module, which is to be tried on all the patients. And what we do very, 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 very specifically before we give thymosin alpha to any patient, and that is the fourth point, that means we always do something called as endometrial profiling. We will never not do an endometrial profiling. If in endometrial profiling, mum1 is absent, that is no chronic endometritis, but uterine natural killer cells are more, that means occupying more than 30% of the slides. In that situation, we strongly consider at this moment, in this criteria alone, we strongly consider at this moment to give adjuvant therapy with this. There is one more contraindication. If BCL6 is positive, that means there is silent endometriosis, and again there is no role of giving thymosin alpha to the patient. So this is something which you have to keep in mind when you do it. We do not recommend blanket thymosin alpha. We do not recommend it at all, that you look at a patient and you bindas give thymosin alpha. That is not done. I do not think that type of a situation should arise for a patient, and I do not think we should consider giving this drug at that point. I also personally think that before you give thymosin to any patient, for God's sake, learn to take from your patient a proper consent. That should be an experimental consent, where you tell the patient explicitly that this is currently purely an experimental module, and it is not something which will change the game for you as far as immunology is concerned. If in case the patient has taken a lot of these adjuvant therapies, I personally also do not think that you can attribute a positive pregnancy rate at this moment to thymosin alone. You will have to attribute this positive pregnancy to a variety of other factors apart from thymosin. Okay, with that, probably I think I have mentioned everything as far as practical information of thymosin is concerned. I shall be happy to answer your questions now.
Yeah, excellent. So you think it is only for endometriosis cases at this moment that you have used, and you can tell us about only that one?
Maybe so, ma'am. I mean, I don't think it has got some massively great output in any other situation. I don't think so, ma'am.
Yeah, initially we thought we will try it out with just like routine RPL also, but then you were and also tell me, like, initially we were discussing whether all endometriosis patients should be given thymosin just to prevent recurrence.
Yeah,
I mean,
no role.
regardless of
No
nothing,
role, ma'am.
right?
No role.
No role. Yeah. So in this situation, like, how do you monitor? Like, do you do any counts? Do you do anything in cases where you are giving thymosin?
We don't, ma'am.
Nothing at all. Have you
As I
seen
told you,
any?
the criteria is uterine natural killer cells on endometrial biopsies.
Yeah, yeah. And have you seen any patients having any reaction to thymosin anytime?
Some of them may develop, madam, little bit of feverish tendency.
Yeah.
That is simply due to, higher immune modeling, which may occur. I actually do not know what dosage works, ma'am. The problem is there.
Yeah.
I do not know if 1.6 works. I do not know if 3.2 works. I do not know how many days you require to do it. It's very tough to predict that, ma'am. So it is not something which it's tough to predict, ma'am. So I will definitely, as a person, I use a lot of thymosin. There is no question in that, but I use it with a lot of caution. There is no question in that as well.
Mm-hmm. Okay, sure. Thank you. I think this was a class which was needed at this moment, because so many of these companies come and meet us to prescribe thymosin, and they give various indications where it can be taken. So this, I think, gives us some insight as to your usage and also your practical experience.
Yeah.
Thank you very much. I think I share the same views, where I could not find it very useful when we were giving it in 2024. So we stopped it. But thank you. I think over a period of time, probably we will come up with more clarity on the usage, dosage, indication, contraindication, and also probably the efficacy of the same. So thank you very much.